Good morning, everyone. Can you hear me? Is that on? Take it that's a yes. Look, just quickly, there's not much time, so I'm not going to go through every slide. Once again, you put together a PowerPoint, you end up with a lot of information and not time to go through it. So a lot of this is replicated in our storyboard out there. So basically, it's my privilege to represent our project group. And just to touch on our initial aim statement, and that was to reduce our seclusion events, number of people secluded, hours of seclusion by 10% each quarter through till December 2020. And if everything works to plan, it'll be 0, 0, 0. But just to give you a bit of an understanding of how we're tracking, and again be mindful this is during a period where we've got a number of PDSA cycles actually in action. So the total hours of seclusion in April was 355 compared with a maximum of 531. And that 531 is from some, equations worked out from where we had our sort of baseline through to the end of 2020. So that is the area where we are doing reasonably well. And that's linked, I think, quite directly to one of our PDSA cycles within our intensive care unit. The total number of people experienced seclusion, we had to track around 11 each month to get to our 0. In April we're at 14, so we're higher, and therefore we've got a bit of catching up to do. Number of events compared with a goal of 24 was at 27, so in those two areas we're mindful that we are not keeping pace with our 10% target. I guess this is the total hours graph, and the green line is the one we're trying to keep very close to, which will bring us to 0 seclusion. This one here is the number of events. As you see, we're going in the wrong direction of the green line. And again, with this one here, the number of people we're heading, well, it's coming down slightly in the last 2 or 3 months, but there's quite a gap between our 10% target line. Our process, we have a weekly meeting, and sometimes I feel the enthusiasm and interest might drop off, but just thinking about the meeting we had yesterday, we had a large number of people in the room, which was really encouraging that people are still really trying their hardest to fit it into their busy schedule. It's multidisciplinary, it's made up of a range of professional groups and other stakeholders, family, consumer and cultural. Onto the PDSA cycle work. This one is, I think, clearly reflecting the total hours. We talk about 9B seclusion. So we started off probably a wee bit grandiose, and we thought that we could apply PDSA cycles across the whole service. But what we found quite quickly, and with, I suppose, advice and teaching from the Commission, is to actually dumb it down a bit and actually focus on separate units, because things are different in different places. And then the areas where we feel we're doing well, hopefully other units or other areas will replicate that PDSA cycle. And I say that because this is Ward 9B, which is our intensive care unit. And the intention is to audit every seclusion documentation with the hope to reduce seclusion duration and to audit each seclusion event. So through this period, there's been 160 audits completed, and 80% of them have required further input. The driver behind, which is about 128 of the 160, which says to us from a starting point over the last few months, there's a lot of work to be done in relation to individual clinicians' practice. And the driver behind that is our clinical nurse specialists in 9B, and along with others. So again, it's about involving as many people as possible in the ground. So we will, moving forward, start talking about how this process can be replicated in the other 3 areas where seclusion is used. A graph, again, on the bottom here, we're just trying to indicate at what month we introduce different PDSA cycles. So I think you would say there in the last, say, 6 months in that area, things are variable, up and down. The intention is, the hope is that that variability will reduce and things will really spike in the right direction downwards. Our approach has been right across the service. We have had probably as much energy put into the wider service as we have in the inpatient areas. We have put a lot of energy into sensory modulation, and led by our, one of our charge nurse managers of our emergency department. And part of the pathway into our mental health service comes through our ED department. And so we've targeted our ED department, providing a sensory modulation approach. And it's increasingly becoming more popular, where people are in a very inappropriate waiting room, often distressed, and waiting to be triaged through to our mental health service. So 40 sensory modulation packs have been given out. Education has been provided to our emergency department colleagues. And yeah, and there's also been some sort of ongoing rolling display within that department. And we're in the process of applying for more money to replenish our sensory modulation packs. So just a wee graph down the bottom, 80% of emergency department, 80 staff have been trained, 40 packs have been given out over 4 training sessions. Another area we're putting a lot of energy into and have a lot of work still to do, but our police across the district are on board. We've got 3 policing regions. It's a large geographical area and it takes a lot of liaising. So this is all coming off on the back end of a very, I think, effective police liaison model we've got set up. And so we're providing de-escalation training and also trauma-informed care training. One of our hopes is to see a reduction in the number of people that come to our service in handcuffs. And that's hopefully that will be one of our measures moving forward that will demonstrate that people are thinking about different strategies. Again, a lot of this is in the context of being aware of the number of people that do experience seclusion within 24 hours of admission. We're targeting areas where we think the level of distress could well be escalated or increased by how people are engaged with right from the beginning of their journey. So basically we're saying there, we've been lucky enough to have sessions with 50 police. There's been 15 episodes of handcuffs in 2018, and we have 3 training sessions thus far, but we've got a lot more we're working with the police to roll out. Baseline information about handcuff use is a wee bit hit and miss, because it's often actually buried in an incident report that may be focusing on the reasons why a person was admitted. So it's a wee bit hit and miss there, but that's the best we could get for the purpose of having some baseline information. Keep going there, our Maori cultural PDSA work. We've gone through a process of change where our Maori directorate is slowly coming back into our own directorate, our mental health addictions and ID directorate. One of the things we were aware of was that people may not have been seen in a timely enough way. This is improving quite significantly. We do think there may be a little bit of a data issue here because the presence of our Maori cultural staff from Te Aronga Tungatanga, it's certainly improving as they are able to actually have the time to be more present. We do want to work towards having a more rapid availability of our Te Aronga Tungatanga staff in our emergency psychiatric service. We do know there's definite evidence which talks about engaging with an appropriate or the relevant cultural advisors or leaders for any cultural group does have good outcomes. And so that's an important piece of work. We just, for example, there are 2 main admission areas. One's an open ward, one's a closed ward. We're saying that there were 12 people that were, I'm going to say, identified as Maori. This is a wee bit confusing, but I think actually 6 identified themselves as being Maori, but somewhere in our stats we're saying there's 12. And it's only saying 3 were contacted within the first 24 hours. We're actually saying it's more than that. We don't think people are putting in their IPM data. But again, this is a starting place, so we're not getting too hung up about the accuracy of data. The important thing is that these people are having a presence. And we know that they are having a presence because we see them in the area very regularly. Our debriefing one, which we know is incredibly important, and what Johnny, who's our consumer advisor, I think is catching a later flight this morning, did a bit of a word salad for us based on feedback that they're picking up through the debriefing. And we all know how this works. Some of the larger font words will indicate that there's people express frustration, angry, threatening, claustrophobic. And what we haven't done yet, and it's work which will be ongoing work, is make sense of this. And I imagine in the future, if we did the same again, hopefully those ones that are in larger font will be in smaller font. So it's just a way of demonstrating some of the feedback of the work our consumer advisor is doing. Yay, I've got long to go, thank you.
Great job.
Okay. Look, this is a wee bit busy. This should also be on our storyboard, and it'll take me 3 minutes to describe it. So basically what we're just trying to display is the proportion of admission secluded within 24 hours of admission. So down the right's number of admission and the percentage, which is the proportion, and the different bars there indicate different areas within our DHB. But I won't go through it, it'll take too long. A couple of balancing measure graphs, again, they'll be on our storyboard. And so just to finish, really, it's just barriers or opportunities. I think we pride ourselves in trying to take the positives all the time when we're representing or presenting this program locally. And so it's continuing to support and foster staff's high level of enthusiasm in the project to ensure the momentum is maintained. And this is in an environment which sometimes it feels it's very hard to maintain it, particularly when people that are doing the work at the coalface are battling with what's right in front of them. But to keep this at the forefront of their mind it's really encouraging, where it more often is than not. And so we just want to keep continuing the co-design process, keep learning. We generally have very good turnouts with the Zoom tutorials, and which I think is an indication that most of our team do make an effort. And I think some of the quality improvement models or processes are now starting to spill out in other programs locally. So I think that's been a huge advantage to our workforce, those of us that are involved in this.